Hello, everyone, and welcome to today's QI clinic for the NJIN and NJAFP ECHO project, Process Mapping and Workflow. Before we begin today, I would like to go through some housekeeping items before I turn the presentation over to our presenter. Our disclosures are for today that planners, reviewers, and speakers of this presentation have no conflicts of interest in the development of this presentation. A few housekeeping items. For educational and quality improvement purposes, this tele-echo session will be recorded. By participating in this session, you are consenting to be recorded, and we appreciate and value your participation throughout the session. To protect patient privacy, please do not provide any PHI information today. And if you have any questions at the end of this presentation, please email us at mweinstein@njaap.org or jsatmir@njaap.org. Please mute your microphone when you are not speaking throughout the session. If you're on your computer, the microphone is located at the lower left or top of your screen through the Zoom application control panel. If you are on your telephone, please press *6 to mute and unmute yourself throughout the session. Please communicate clearly during the session, and please speak clearly. If you have any questions and you don't want anything to go over, if you don't want to say anything over the phone or through the application, please send them via message through the chat function through our Zoom application. For any IT help, please chat NJAAP admin. Please do not put your phone on hold if you must leave the meeting. We will hear hold music throughout the session. For today's learning objectives, following today's session, participants shall be able to summarize how design of work impacts outcomes and select a workflow and apply process mapping to analyze. And now for our accreditation statement. Application for CME credit has been filed for the American Academy of Family Physicians. Determination of credit is currently pending. Each physician and clinician must complete the evaluation to receive credit. You will receive an email by close of business from Jake with an evaluation link.
Okay, hi everyone. I think that concludes Jake's introductory part. So again, just to come back to the learning objectives for a moment. So yesterday, if those of you were on the call with the physician clinic, we talked about how the design of work can actually impact outcomes. And basically that if things are being done differently, then we're going to get different results. So if vaccination rates aren't where you'd like them to be, one of the things to consider is looking at how the work is currently designed to assess patients for vaccinations, collect that information, document it, and facilitate patients getting their documentations. And if that's not being done in standardized ways, then it's pretty likely that the results are not going to be exactly where you want them to be. So we talked about that a bit yesterday and learned that some of you are already working on some standardized approaches, which is great, and that there may still be some other opportunities. So we'll chat a little bit more about how work can impact outcomes. I'm not going to repeat what we did yesterday, unless folks were not on that call and would like a little more info on it. We can definitely do that. And the goal would be to talk about one of the ways for decreasing the variation in way things are done is to first map out the process. Some of you may already be familiar with doing this, and if not, we're going to go through a bit of how do you do that and select a process. So before we delve into that, we want to start on the next slide with what we talked about last month. The way we have these calls structured is every month we're going to follow up from what we talked about last month, hear from all of you what's been happening, and then we'll delve into the topic for today. So last month we talked about the challenges of capturing race and ethnicity data or even other demographic data, getting it from patients, getting it into the electronic health record, et cetera. And we asked everyone to identify one change idea at a minimum and test that out using a PDSA cycle. we'd like to start with an interactive portion to hear what change idea did you identify, excuse me, and what did you learn from testing? Or if you identified a change and then ran into an obstacle that prevented you from testing, what happened? Because we'd like to learn from that as well. That might be a good opportunity to think about what you can do going forward. So with that, we'd like to hear from you. If you're on the phone or you've got audio on your computer, you can call out. We're not a real large group, so we'll try just having folks shout out. If you prefer, you can type into the chat. Just please make sure you send your message to everyone. We can all see it. All right, it's really quiet out there. This is the first part that's interactive. And again, if you weren't able to test anything, that's okay. We can learn just as much to test as testing. It would just be great to hear from folks.
Hi, can you hear me?
Yes, we can hear you.
Okay, I had my mic muted and I was talking and you couldn't hear me. This is Jackie from Virtua.
Okay, great, thanks.
I was on last month and we talked a little bit about how difficult it was to capture the race data, just in that all of the, there's different categories I think that you guys have than what we had and in our EMR. And it was also difficult to get people because everybody's self-reporting. I really didn't have a chance to test it, but we did talk with this front desk staff about just making sure to ask those questions and to go in and seeing where it wasn't identified, because that's one of the things that they weren't focusing on. They were focusing more on the other demographic information, having the names, phone numbers, and email addresses correct, but to go in to look for that. But yeah, it's very difficult to test because a lot of our registration is done outside of our office.
So were you not able
we use
because of that?
I'm sorry, we use like a call center. We have an access center team, and they do a large portion of all of our registration, so we miss some of that.
Gotcha. So, I mean, that can be challenging. So one of the things to think about is there something on your end, because to try and start testing with something you can control, that you could do? So when you think about the process of when people arrive, are there any kind of checks that you do for demographic data and race and ethnicity data? Is there pre-visit planning? Is there some step in the process that you could do differently or add to in order to try and identify early that that data is missing and try and capture it?
Oh, definitely. I think that it could be a part of our check-in process. Like I was saying, we've been focusing so much more on the phone numbers and the emails, making sure that information's accurate. But to add the race and ethnicity to it on our end is something we can do.
Yeah, and again, you might just want to even test it out on a small scale, see how well would that work, or would that put a big burden on your staff? Because
right,
then you might need to think about a different approach. The other thing we often talk about with, because hospitals, I've done a lot with hospitals, often face similar challenges. Different departments own different pieces of the process, and that sometimes presents an opportunity to partner and say, let's get together with the folks who should be collecting this data and see how could we make it happen. I mean, do they know that you even need it? They might not even realize how important it is for looking at population health metrics to have that information.
That's true. We do monthly calls with that team, so it's something that we can bring up.
Yeah, you might want to think about showing them how you are thinking about using the data. Years ago, when I was working in one of my hospital jobs, we were having a challenge with getting the ED registrars to collect zip code, because when ED was all backed up and there was a big long line and people were sitting in the waiting room, they were just trying to crank people through. And so they didn't think zip code was the most important field, so they kind of skipped that one. And when the infectious disease people came and did a presentation on how that information is important for reporting to CDC or public health departments when an infectious disease or an issue like food poisoning is identified, and they understood why zip code was so important. Once they realized that, the zip code capture rate went way, way up just by sharing with them how it was being used and why it was important for clinical purposes.
Okay.
And they just might not know. It's worth a try. You never know.
Absolutely. Thank you.
Great. All right. Well, thanks for sharing. Really appreciate you going first. Let's see if we can hear from at least one other participant. We've got almost 10 on the line. And if you have an idea for something that you were thinking of testing and you didn't get to it and would like to just kind of bounce it around the group, that would be fine too. Very quiet group today. I hope people aren't like Christmas shopping while we're talking. On my mind, because I was doing that this morning before I joined this call, down to the wire. All right, well, let's move on a little bit, and maybe we can get more folks sharing for the next part, which I'll just give you a heads up is going to be what we asked on yesterday's call with the physicians and those of you who are on, to think about a process within vaccination work or a workflow that you might want to map out for looking at standardization. So, so flowcharts or process maps. Some of you may be familiar with these already. They are one of the basic quality improvement tools, very commonly used, can be done really, really simply, which is one of the things I'm going to emphasize today is the simple aspects of it. Because sometimes when you see these, they look really complex and complicated, and they can be, and building them in programs like Visio can be a lot of work, and I know that you don't all have a lot of extra time, so I'm going to talk about how you do them in a really simple way. But why they are important is, and I like them because they give you a visual. I'm a very visual person. And so they give you a visual layout of the steps in a process. Now, what's really key when you're making a process map or flow chart is that you map the actual process, not the ideal process. I often see folks get tripped up because they map out what they think is supposed to happen or that they wish would happen or what the policy and procedure says. But as we all know, the way work happens often doesn't reflect what was in the policy and procedure, especially if it was developed a while ago. In some other work, this has been recently referenced as work versus imagine versus how work is being done. So it's very important that it reflect the reality, including with all the good, the bad, and the ugly, and all the bumps that happen. That's really important, because if that's not captured, then you'll be trying to fix an ideal process that doesn't really exist, or it won't show that there's anything that needs fixing. So the key in a process map is that it shows the steps as well as decision points, and then where the process may go based on the decision points. So the decision points is a great place to capture where your process might vary. Does it vary depending on the type of visit that the patient is there for? Does it vary depending on which physician they're there to see? Does it vary depending on day of the week? Those are really key things to think about when you're trying to look for where do we have things varying that we might want to try and standardize. It's absolutely essential that before you work on changes, that you understand the current process. So even we were just talking about, off-site registration call center, it would probably be really good if you're going to talk with them about how can we capture race and ethnicity data to have a good understanding of what does the current process look like before trying a change. Otherwise, the change can really mess things up. The other good thing about process maps is, especially if you put them up on a wall or make them into a poster or use other simple tools like I'll show you in a moment, you can actually make revisions to it while you're testing ideas so that you can talk through, well, if we do this over here, what impact does it have further down? And the front line, the people who are doing the work, are critical for that discussion. So on the next slide, we have some of the common symbols. Now, if you go into Word or PowerPoint, these are all actually in there. If you go to the shapes section, and if you go in there, you will see an overwhelming number of symbols, some of which I have never even used myself, and I've made many flowcharts and process maps over the years. Basically, these are the 4 you really need. The start and end point is usually represented by a circle. A step in the process is usually a rectangle, and a decision point is reflected with a diamond. And then we have arrows for showing the direction of the work. You really don't need any more than that. And some of the best flowcharts I have seen when I've worked with folks on doing quality improvement projects use nothing more than these 4 and are sometimes just drawn on a piece of paper. You do not need to use technology to do this. Again, the shapes are in Word, Excel, and PowerPoint if you have it. And so if you're technology savvy and you want to do that, you can go in and do that. I find it easiest to do it in PowerPoint because it moves things around nicely and you can type directly into the box. But again, handwritten is fine. So let's look at an example. So this is an example on the next slide, please. Thank you. I took this off of the IHI website, and I put a link to the website down there because they've got a lot of information on this, and it's all free, so feel free to check it out if you're going to do this. But here's an example based on a patient possibly having an MI. And so you can see they did it a little bit differently. They don't have the starting and ending point, but it shows that the starting is the patient has acute symptoms. And so the question is, when the patient is triaged in the ER, is there evidence of an MI? And then you can see there's a yes and a no. So with decision points, it's really best that there's only 2 choices most of the time. If you get into 3, it can get really messy and not work very well. So we try to keep these to 2. So if the answer is yes, the chart goes one way. If the answer is no, it goes another way. And then you can see further down on the yes answer that it goes through several steps, and then there's another decision point, and then another decision point. And so this really helps you think through what is the sequence of things that happen and where does it vary. So on the next slide, I made just a very crude example of something that might happen in a practice. So here you can see the starting point is the patient arrives. And so I color coded that in blue. Color coding on these can be really helpful so that you can sort out steps versus decision points. So this one was from something I was working on with another practice around waiting time, where we started to color code all of the places where patients would wait to see where could we eliminate them. You could do that for anything. So with the decision boxes, like you see, the first one is the reception window free? You might have something like, is the patient here for a well visit, yes or no? Does that cause the process to vary? If it does, then I would put that in as a decision point. If it doesn't, no need. But you can see the patient arrives, is the window free? No, then the patient waits. If yes, the patient checks in, then the patient gets called in, their vitals are checked, and then they wait. And then the physician arrives. So this is just kind of a general, there'd be more steps obviously after that. Sometimes when we do this, we only do a small portion of the process because the entire process might be too big. So if you think about the entire visit from the time the patient arrives until the time the patient leaves, that might be bigger than you need to do. So if you were going to work on, for example, collecting vaccination status, perhaps you would use from the time the patient arrives until the time the vitals are checked, if the MA is asking that question or if the reception is asking that question. Think about where that fits in. It's really important that these are actions, so the boxes should be actions. I did additional boxes for weights just because that's what we were working on here. Things can be happening at the same time. Remember to try and keep it to 2 answers on decision points. If you come up with more than 2 answers, then you might want to go back and look at, did we miss a step? Because that's often a signal of that. And you don't want to list steps twice unless they actually do occur twice at different times in the process. If something shows up twice, then you should look at, do we have our arrows going in the right direction? And again, you can do all of this on paper, and I'll show you a paper example in a moment that was done really simply with some Post-it notes. So with that in mind, on yesterday's call, we asked all of the participating practices to think about what process might you work on. So on the next slide, I just kind of have two questions, and we'd like to hear from the group. What process or what workflow related to vaccines did you select? Hopefully you had a conversation about it. What is the starting point? And what are the first two steps? And hopefully we can get some volunteers to share that. And if you didn't select one, you can select one now. Think about if you were going to try and work on improving vaccination rates by decreasing where things are done differently, what might that be? Is it collection of information on status? Is it documentation? Does it vary by type of vaccine? Does it vary by type of provider? What types of opportunities do you think might exist in your local setting? Well, let's see if we can get a different volunteer this time. And again, if you didn't have a conversation yesterday, just some ideas on what do you think might be one that you could talk about back at your practice. And if you think there's no opportunity based on variation, we'd very much like to hear about what you've looked at and how you learned that that might be the case, because that might be useful for others. Has anybody already done a mapping of steps related to vaccines? This is supposed to be the interactive part, folks. I don't have a whole lot more slides.
Hello?
Yes, hi.
Okay. Well, honestly, I think it's just a mixture of all of those things put together. Like having the MAs, the front desk, ask about the questions, whether they've been vaccinated on our end to check their immunizations, because as you know, you can lose immunization to such things. But honestly, I don't think there's just one way it can be done. I think everything that we've mentioned, it's a little bit of all 3, 4, 5 things that we mentioned in order to get, the numbers that we would like to see. So, in my opinion, I think all of them combined could be things that can be improved on.
Yeah, absolutely. And if there are multiple different ways the work is occurring, that typically leads to results that are not where people want them to be. It's kind of hard to break past 90% when you're tracking a process if there's, 3, 4, 5 different ways that the work is actually occurring.
Right.
And who's that speaking? It would be great to know.
This is Patrick Twill, one of the residents in family medicine for Riverside and Palisades.
Okay, great. Thank you so much.
You bet.
All right, how about some others? So I'm actually going to, let me see if we can get a sense of this, because there could be a little bit of a gap from yesterday. If everybody could please type into chat, yes or no, were you on the call yesterday where we talked about variation? Okay, yeah. Yes. Okay, so I'm seeing mostly yeses at this point, a couple of no's. So the reason I asked that is, you may recall yesterday when I showed some real data based on other processes, that you can be above 90% for how well something gets done, and still have a great deal of variation. and have some patients falling way outside of the goal. And so the same thing, and when we're looking at the data that has been submitted so far for vaccines for this project, the best result we've seen has been for pneumococcal. And let's see, maybe since people are typing into chat, I'm going to take advantage of this. What do people think the top percentage is that we have seen in data from all of you participating in ECHO for patients age 65 and older getting the pneumococcal vaccine? What would be your guess? And if you are phone only, you can shout it out over the phone. And please do it as a percent. What percent do you think was the best that we've seen from the baseline data? So the 5 of you who just typed in answers to my questions on were you on yesterday's session, hope you'll type a percentage in as well. Just looking for guesses here. Great, all right, thank you. We got one at 80%. Anybody else? Okay, another one at 70. I'm gonna hold out for at least 1 or 2 more. And again, phone folks, feel free to shout out. All right, looks like folks are hesitant to put a guess out there. Oh, we got one more. Thank you very much, 75%. So the second answer was actually the correct. Oh, there was a 4th one. Thank you. So 2 of you put 70, and that is correct. The best result we saw for the baseline data was 70% for pneumococcal. And that was from one practice in particular. In fact, I think it was Palisades, if I recall correctly. It was also the vaccine that had the highest percentages across the board from those who submitted data. The data that, anybody want to guess which vaccine had the lowest percentage? So the vaccines that we're tracking are pneumococcal, influenza, HPV, and shingles. And shingles we're capturing in several age groups. Okay, we've got one guess for HPV. Oh, lots of guesses for HPV. 3 in a row. Going to give it another moment or two. So HPV was a bit low, but it was actually not the lowest. The lowest was shingles in age groups under age 65, particularly in those aged 50 to 60. Those were the lowest groups. And I mean, really low, like less than 10% for almost everybody. So lots of opportunity across the board. So across all of the data, and the only reason we haven't shared the baseline data more broadly is we are waiting for data from one more practice so that we can finalize it and give you a good picture of how things look across the group, although you can see some of it on Simple QI. As far as the monthly data, we've got opportunities across the board. Nothing is at 90%. And only pneumococcal is around 70. Everything else is, for the most part, 50% or lower. So that definitely gives us opportunity. So I would encourage you very strongly to think about processes around vaccinations and mapping them out to get a sense of what's the current work look like and where is it different depending on visit type, patient type, vaccine type, provider type. Might provide some good learning. I do have a picture, just to show you on the next slide, of how some places do process mapping in really simple ways. And that is they get a big piece of poster paper and they get Post-it notes and they write the steps on Post-it notes. And what they do is sometimes they start off with what they map out the original process to be, and then they use a second one to show how they're changing it. And the advantage of doing this is they get a bit of a before and after, and it also gives them the opportunity to get a sense of real-time change. And so they just move the Post-it notes around depending on how they change the process. So again, it's an example of how you can do this without fancy technology and really think about what are the steps in the process. So I would encourage you to think about, even if you just take a chunk of a process, just a few steps to map that out, because actually that's our action request for today's session, and also what we're going to be talking about at the beginning of the next session. So if we just go to the next slide. So that's our action item. You guys are all really quiet today, and I'm not going to just fill with 10 minutes of me talking for the sake of filling 10 minutes. I'll stay on for anybody who might want to talk about process, talk about how to get started, if that would be helpful. But our action request to all of you is to map the steps in one of your workflows related to vaccines so that you can get a sense locally about what do the steps look like, where might there be opportunities to standardize, remove steps, move steps to a different place, and use that as a way to increase the percentage of patients with vaccination status, either the vaccine being administered or capturing the documentation so that you have that in the record. We will discuss that on the January 22nd session, which is our next QI session. I'm hoping that some of you will come ready to share what you were able to learn, and we're not meeting until the 22nd, so even with the holidays coming up, we've got lots of time to do this. It doesn't take long to map out just a portion of a process. Even better if you do that and send it to me, then I can share it with everybody in the slides. It would be great to show some examples during the session on 22nd, and you can just take a picture of it with your phone if you like and send it to me that way. I've done that in many other programs, and it's a really effective and easy way to create a map and then send it and share it to everyone. We do want to remind you that we're looking for monthly data on Simple QI. If you haven't posted it yet, 2 practices had last time I looked. We would like your monthly data for November on Simple QI already, and hopefully you can get your December data up there by January 10th. We're also looking to see what changes you test, what things you do, and using the PDSA information on Simple QI. Anyone who puts in data or puts in a PDSA cycle, I will email you to give you some thoughts on it, some questions to hopefully help you think about what comes next. And of course, I'm always available for assistance since I'm doing the improvement advising for this project. You can email or call me at any time. So we'll just go to some Q&A. For anybody who has questions or if there's something you'd like to get feedback on before we wrap up. If not, I know you're all in the midst of busy days trying to see people before perhaps holiday break, so you can feel free to drop off at this time, and Jake and I will stay on for a few minutes for any questions that anyone may have. And again, if you have a question or there's something you'd like to discuss while we're on the line, just shout it out or type it into the chat. If you have no questions or are not looking for any feedback on anything, please feel free to drop off. If we see the numbers going down as people head out, then we will close out the session. All right, it looks like we should probably wrap up today. So thanks for joining, everyone, and have a happy new year. And we look forward to hopefully everybody being more talkative in January.
Thank you, everyone, for coming today.